Welcome friends. We are quickly going to revise the main topic, that is cardiac disease in pregnancy. Patient which we have either as pregnant lady or in labor, she is having a heart which is already diseased. That heart is just trying to compensate for her own body, but now there is added load on that heart of the pregnancy. The baby is requiring blood. The blood volume is going to increase as a normal physiological change of pregnancy. There would be pain during labor. That time her pulse is going to increase. After the delivery, whatever blood volume is there in the uteroplacental circulation, that's going to come in her own circulation. And at all these points, the ailing heart or the diseased heart is going to have overload. And then this heart is likely to fail. So that is why we have to know that which are these points where we have to be extra cautious, what things we should be doing, which are those diseases where vaginal delivery is to be advised, where are those things are contraindicated, cesarean section should be preferred, which patients need anticoagulants, what anticoagulant should be given if there is prosthetic valve, what care should be taken in puerperium. So all these things we want to learn and remember from exam point of view. So let's see. Cardiac disease, almost 1% of all the pregnancies, it complicates. Now the rheumatic heart disease percentage is going down, but still it is there. Maximum mortality is seen in Eisenmenger syndrome. You have to remember this name, you cannot afford to forget. Eisenmenger means there is almost 50% mortality if the patient is pregnant. Commonest cause of maternal mortality is cardiac failure. There can be other causes like endocarditis, embolism, pulmonary embolism, arrhythmias, but the most common cause is cardiac failure. And heart diseases are still the second most common non-obstetrical cause of maternal mortality. Which are the common diseases? The commonest disease is rheumatic heart disease, still at number 1. Second is congenital heart disease, maybe cyanotic, maybe acyanotic variety. Others are hypertensive heart diseases, coronary heart diseases, thyrotoxicosis, syphilitic lesions, idiopathic cardiomyopathies, cor pulmonale, constructive pericarditis, and myocarditis. We know that physiological changes happen because the mother has to grow or nurture this pregnancy inside her uterus. And thus there is increased in blood volume, plasma volume. It starts by 5th week. 35% increase is there by 12 weeks. But peak rise, that is almost 40 to 50% increase in cardiac volume, is by the end of 30th week. That means 30 to 32 week period. So you understand that at that particular period, the changes are maximum. So cardiac workload, there can be cardiac output is product of volume plus pulse rate. So both the things are increased. There is even pulse rate is increased by 10 to 12 beats per minute in pregnancy. So because of that, cardiac output is increased and the maximum load is around 30 to 32 weeks. So first place where we should consider that this heart may fail. 50% in the rest of the pregnancy, the cardiac output is raised. During labor, tachycardia, stress of labor, bearing down by the mother, 60 to 100%. And highest rise is when the delivery takes place. Suddenly when the baby is out, placenta is out, minimal blood loss is there, but now the uterus is retracting and the whole volume is coming back to her own circulation. That is called autotransfusion, and there is release of this aortocaval compression which she was bearing with for last 9 months. So because of this, these 3 places we should be always cautious when we are dealing with heart disease patient, that around 30 to 32 weeks, during labor and immediately after delivery in puerperium. The cardiac output is lowest in sitting and supine position and it is highest in left lateral. The reason is obvious. The pressure of the gravid uterus is removed when the patient is in left lateral position. That increases the venous return and thus increasing the cardiac output. Changes in heart. The heart is pushed upwards, outwards, and there is little rotation towards left during pregnancy. So these are all physiological conditions. If you find these changes either on X-rays or on ECGs, you should not worry about them. Apex bit is in 4th intercostal space, 2.5 cm away from the midclavicular line. Heart rate is raised by 10 to 15 beats per minute. There is split first heart sound, systolic or mammary murmur is present because of increased vascularity, slight increase in cardiac silhouette is there, and on ECG you will find there is left axis deviation. So all these are physiological changes, and these are the reasons why the heart is going to get overloaded. Now what are the complications seen? Major complication, maternal, is cardiac failure, and that may lead to maternal mortality. Then there can be endocarditis, there can be pulmonary edema, there can be thromboembolism. So all these changes can be there, but main is cardiac failure, main cause of maternal mortality. So that woman who's pregnant, just because she is pregnant, she may die. Fetal complications, there can be preterm deliveries, prematurity is the one. In cyanotic diseases, the blood supply going to the fetus is compromised, so there may be abortions or even IUGR is seen in these cyanotic diseases patients. And usually, if a mother has congenital heart disease, it is found that the babies are more likely to have congenital anomalies. So increased risk of congenital anomalies in the fetuses. How do we diagnose? Usually patient know that she has some disease, but sometimes they may not know. So there are certain clinical symptoms which will guide us that this patient may have heart disease. Main is dyspnea. Patient is dyspneic, or there is orthopnea, that the dyspnea increases on lying down position. There can be nocturnal cough, hemoptysis, chest pain, or syncope. So if these patients are there, we need to evaluate the patient during pregnancy so as to detect her cardiac disease. Signs would be, fingers would be showing clubbing, chronic heart disease. There will be cyanosis, persistent neck vein engorgement, systolic murmur, but of high intensity. The grade would be 3/6 or greater than that. Then there can be late systolic murmur or ejection systolic murmur or pan-systolic murmur, and diastolic murmur is classical of heart diseases. Cardiomegaly will be found on investigations. There would be persistent arrhythmias or persistent split second heart sound, and or there would be presence of pulmonary hypertension, which is very critical. Investigations, chest x-ray, usually with the guard given to the pregnant lady on the uterus. ECG would show those physiological changes. Along with that, if there is arrhythmias or T-wave inversion, they go in favor of cardiac disease. Echocardiography is standard investigation. It would confirm the lesions like ASD, VSD, whatever lesion patient has. Along with that, it will give us the ejection fraction, which may be compromised during pregnancy. The New York Heart Association has classified the classes of heart diseases according to the function. Class 1, how is the patient? She is uncompromised. There is no limit to her physical activity. That is class 1. Means this patient is having good prognosis. Her physical activities are not restricted because of heart disease. Class 2, there is slight compromise, slight limitation to physical activity, maybe at unaccustomed exercises or work. Class 3, there is markedly compromised patient, marked limitation of physical activity, maybe to the accustomed work. And class 4, severely compromised, inability to perform any physical activity without discomfort. That means she is at discomfort at rest. So that falls in class 4. So whenever we have a patient, if she comes to us preconceptionally, we should not miss the chance to counsel her about the cardiac lesion she has, what is the prognosis, what is the effect of pregnancy on that cardiac lesion, what would be the effect of that cardiac lesion on the pregnancy, what is her risk of having mortality, especially in cases of primary pulmonary hypertension, primary or secondary. Whenever there is pulmonary hypertension, we should counsel the patient and tell her everything, that what would be the effect, and then only she should go ahead with pregnancy, because there is a lot of danger of decompensation during pregnancy. Especially in cases of Eisenmenger syndrome, we should warn the patient in strict language that it may be life-threatening. Now, there is one more classification, group-wise, where the risk for maternal mortality caused by various heart diseases has been mentioned. Different cardiac diseases like ASD, VSD, PDA, patent ductus arteriosus, pulmonary or tricuspid valve diseases, corrected Fallot's tetralogy, bioprosthetic valve, and mitral stenosis patient which falls in NYHA classes 1 or 2. They fall in group 1, that is of minimal risk, and the mortality is minimum, that is 0 to 1%. So MCQs might be asked that which is the most dangerous disease, and if 3 of them and 1 from the 4th or 3rd group is given, you have to identify that. So please remember, I'll again repeat, group 1, minimal risk. The diseases are all congenital heart diseases like ASD, VSD, PDA, then pulmonary and tricuspid valve, Fallot's tetralogy but corrected one, valve replacement, mitral stenosis but of NYHA classification 1 and 2. Minimal risk, mortality is observed as only 0 to 1. Group 2, moderate risk, mortality is 5 to 15%. The disorders are mitral stenosis, NYHA classes 3 and 4, aortic stenosis. So just get a clue that stenosed lesions are falling in moderate. In minimal risk, we had congenital heart diseases. Fallot's tetralogy, if uncorrected, falls in group 2. Previous myocardial infarction, Marfan syndrome with normal aorta, mitral stenosis with atrial fibrillation, and artificial valve. So any surgery done, and there was in class 1, it was bioprosthetic valve. Over here it is artificial valve. So the risk of mortality is higher in this class. Group 3, major risk. The risk is, maternal mortality risk is almost 25 to 50%. So there are 50% chance that that woman is going to die in pregnancy. It's a gross risk, and it is there in case of pulmonary hypertension, aortic coarctation with valvular involvement, Marfan syndrome with aortic involvement, and Eisenmenger syndrome. These 4 names you should remember, in which you should not forget pulmonary hypertension and Eisenmenger syndrome. Aortic coarctation with valvular involvement and Marfan syndrome with aortic involvement are the other 2. So in that case then, if we warn the patient, if you counsel the patient, I don't think so she would like to have a pregnancy. But suppose such disorders, the patient comes with pregnancy, then there is a scope of therapeutic termination. What are the indications? Pregnancy can be terminated therapeutically in patients with primary pulmonary hypertension, Eisenmenger syndrome, and pulmonary vaso-occlusive disease. Counsel the patient, tell her the risk, and if she wants, go ahead with termination because it is high-risk pregnancy. Paris woman who has children, if she is having NYHA grade 3 or 4 disease, please discourage her for going ahead with the pregnancy. Tell her about the mortality and terminate the pregnancy if she agrees to. Grade 1 or 2 diseases, NYHA classification, but if they have history of failure before, then again their risk increases in pregnancy. We can again advise them termination if they are pregnant. Now, how to manage the cardiac disease patient? It's a team approach, obstetrician plus cardiologist plus anesthesiologist. Good team, tertiary care center is mandatory. All the facilities should be available. Availability of a person doesn't suffice. Anytime any complication can happen. So good care requires a good center plus trained people. Risk to the patient is of heart failure, subacute bacterial endocarditis, thromboembolic diseases, and this risk should be identified on time and treated immediately. We all know, we have to remember that there is increased blood volume now, the cardiac output is increased. There is further increase in peripartum period. We should not forget peripartum period in cardiac diseases. There is decreased systemic vascular resistance and hypercoagulable state the woman is in, who is on anticoagulants to avoid thromboembolic phenomena, and now she is pregnant and pregnancy is a hypercoagulable state. So all these points we should remember when we are managing a cardiac patient. Management of class 1 and 2, low risk people, ask them to come for NC maybe a little more frequently than normal antenatal checkups. Always warn them to stay away from people who are having infections like respiratory infections. They should not get close to them, or they should always take care that they don't get any kind of infection. Again, the risk more in valvular heart disease patients. Diet, avoid strenuous activity, even caffeine excessive use or alcohol should be avoided. We should take care that they should not have anemia, because we already know this heart is disease. Now pregnancy is putting overload. On top of this, if they are anemic, there would be added tachycardia. If there is hypertension, there would be again problem. So these things should be well controlled, and we should not allow the other disorders to get added on already critical situation. Signs of heart failure: if there is presence of basal crepitations or rales, if there is nocturnal cough, even if they can't perform accustomed work, means patient gives clear-cut history that she used to work every day and these things she used to do comfortably, but now she is unable to do. So that means worsening of the symptoms. Increasing dyspnea on exertion, hemoptysis, progressive edema and or tachycardia. These all are symptoms indicating that she is landing up in heart failure. ANC care, as we said, it should be in tertiary care. Counseling should be properly done. They should be warned that the disease can progress this way and these would be the complications. If it would need immediate care, that also in a tertiary center, so they should report immediately. So all these things should be told to them beforehand. If any infections are there, they should be adequately treated. Hypertension, anemia should be under control. Anticoagulants. If the patient is on warfarin, as soon as her pregnancy gets confirmed around or till 12 weeks, we should avoid warfarin. We should put the patient on heparin because warfarin has teratogenic effects. After 12 weeks, she can be on warfarin again till maybe term 36 weeks. Then again, we should shift her on heparin because well controlled. Then after 7 days, from term to 7 days heparin, and then after 7 days we can shift her on warfarin. But during the period of organogenesis, the patient should not be on warfarin. Surgery, if there is stenotic lesions, surgery is an elective thing which is usually avoided during pregnancy. But if there is intolerance to the symptoms, patient is severely breathless, and if she is likely to go in intractable cardiac failure, then we might have to go ahead with surgery, valvotomy or balloon plasty or those things during pregnancy. In labor, we have to be extra cautious because now pain increases heart rate anyways. On top of it, there would be stress. Then on top of it, there would be bearing down. So all these things would add up and failure chances, they increase. So labor and delivery, vaginal delivery is preferable always, even in cardiac disease. Only contraindications are coarctation of aorta, aortic aneurysm and Marfan syndrome with aortic involvement. These are the contraindications for vaginal delivery. To reduce the tachycardia, we can always have relief of pain with analgesics, or we can have continuous epidural analgesia, but that also depends on the lesion and the facilities and the expertise available. Fluid should be balanced. We should not overload the patient. To be kept on dry side a little. Antibiotic prophylaxis is must in all heart disease patients. Semi-recumbent position with little lateral tilt so as to avoid the veno-aortal compression. Oxygen if required, pain relief and SOS diuretics. Intensive medical management for any sign of impending ventricular failure like pulse going more than 100 or if there is respiratory rate more than 24 or dyspnea. So immediately we should have person ready to treat ventricular failures. As obstetrician, we should manage the second stage quickly because that's the critical time. We should expedite delivery in second stage, cut it short either with the use of forceps or vacuum. And the most important thing which we routinely do, that is injection methargin which we give, is totally contraindicated in heart disease patient because methargin will cause sudden retraction of the uterus and there would be sudden autotransfusion. That means the blood would be going into the circulation suddenly. So no active management with methargin for cardiac disease in third stage. Third stage, close monitoring is required. Slight blood loss which occurs normally is beneficial for cardiac disease patient. Oxytocin can be given as the oxytocic drug. Diuretics if required. Avoid ergometrin totally. And no active management again. In puerperium, we have to be extra careful. We should avoid PPH, anemia, infection and thromboembolism. Close observation is must. Breastfeeding is not contraindicated. But in case patient lands up in failure, then maybe if she is not in position, breastfeeding can be suspended for a while. Anticoagulation therapy is very important in puerperium. If she wants sterilization operation, but it should be delayed till she completely recovers and she comes out of that danger period, or the best option is we should talk to her husband and he should be encouraged to do vasectomy. Tubectomy, as far as possible, we should not do in that critical period. If they are not willing for permanent sterilization, then they would ask us what is the temporary method of contraception they would use. So in that case, barrier is of choice. No occipitals are to be prescribed to the patient with heart disease, risk of thromboembolism. Management of class 3 and 4 patients. I would say whether pregnancy to be continued in that is a big question. So we should counsel the patient, warn her about the mortality and discourage her to continue the pregnancy. So consideration should be given to termination of pregnancy in these classes. If patient is class 1 or 2, she can be admitted at around term. But if patient belongs to class 3, then at around 28 weeks, when the period is coming closer of maximum change, that is 30 to 32 weeks, when she is likely to go in failure, she should be hospitalized. And in class 4, patient should be continuously in the hospital throughout her pregnancy period. Vaginal delivery, again question mark. In class 3 and class 4, it depends on the lesion. It has to be decided for that particular patient at that particular situation. Caesarean section delivery if required. We need expert anesthetists who are good at giving cardiac anesthesia, and the center should have good facility. It's not that caesarean section is completely safe in these patients. Let's have this weightage to these diseases which are most commonly seen. Rheumatic heart disease, main cause of serious mitral valve disease in women. Almost 3/4% of causes of mitral stenosis are because of rheumatic. So we should all know penicillin prophylaxis, care to be taken during rheumatic heart disease. We should be well versed with this disorder. The most common congenital heart disease seen is ASD. Peripartum cardiomyopathy is something very dangerous. The diagnosis is usually by exclusion. When we rule out this is not there, this is not there, this is not there, then finally we can conclude that this patient is having cardiomyopathy. The picture is very surprising. The symptoms of cardiac decompensation, they appear during the last week of pregnancy or maybe 1 to 6 months peripartum. Means we think she delivered fine, 3rd stage, 4th stage, everything fine, 8 days fine, she's gone home, and then maybe 1 month later the symptom starts. 1 to 6 months, anytime the symptoms can be there. So this is a disorder which is dreadful. Again, the prognosis is very bad. Obstetric complications such as preeclampsia, anemia with blood loss and infection, they contribute or precipitate the cardiac failure. So we should be very cautious, and we should always remember that such an entity exists. Even though the diagnosis is by exclusion, it should be at back of our mind that we may be dealing with cardiac myopathy. So finally, the conclusion is the prognosis or the favorable outcome for the mother with heart disease depends on what is the lesion, what is the functional capacity of the heart, what are the other added complications including pregnancy, and what expert care she gets. So on all these factors, the prognosis and the morbidity and mortality of that patient depends. So we'll stop here. Thank you.